Welcome to Zoom. Enter your meeting ID followed by pound. Enter your participant ID.
How you doing?
Okay, good afternoon, everyone. This is Alice Gwynn of the Curriculum Department, and we'll have Donna Cruz as well as Tom Funstein, and our guest today is Bernie Mazzullo. Before we get started, we just want to go over a couple of guidelines with you. We're going to have a large crowd, so we want to try to manage that as best as we can. So we're going to have everybody on mute during the presentation. There are features that you'll be able to take advantage of on the Zoom webinar itself. So you can raise your hand if you have a question. It would be great if you just want to chat your question to us. And what we'll do is we'll have Bernie pause after each of his sections, and we'll check if there are any questions or if there's a raised hand. And if that's the case, then you'll be able to unmute yourself. But we really need to have everybody muted because there's always a lot of background noise when too many people have their phones open. So we'll probably about an hour's worth of time here, and we'll give you plenty of opportunity to ask questions. And if you think of questions after the webinar, then please go ahead and send your questions to the FTI International email, and we'll forward those on to Bernie and probably make a list of all of the questions that have been asked and be able to share that with everyone as this pandemic, progresses and more things come out about it. So Tom, I think he's going to do the introductions for us. Tom, are you there?
Yeah.
There we go.
Yep, I'm here. Can you hear me?
Do you want to introduce Bernie for us?
Sure. So at this point, I have a lot of background here.
Yeah, there's a lot of background.
Hold on, give me 1 second. Okay, is that better?
Yes, that's better.
Is that better?
Yes.
Okay. So the last couple of weeks obviously have been some interesting times here. So at the IFTI, we've been busy doing some things here as far as obviously with the virus and getting out some information to our members, as well as doing some things as far as offering some distance learning strategies. And one of the things that we are doing, it is available through the learning management system, and everybody has a e-learning. There's a brief e-learning that's available for everybody in the learning management system on the virus. But also at the last board meeting at the beginning of the month, we have retained the services of an industrial hygienist, Bernie Mazzula, who has obviously, some of you might have met him at FIF. He helped us develop the PCB curriculum along with Jim McAllister and Wayne Cummings, the worker course, as well as the train the trainer, which was supposed to be scheduled during this time. And we'll have more on that when we reopen. But Bernie came on. There was a lot of different things we're going to use his expertise for, as far as promoting a safe work culture. But obviously this came as soon as we signed him up. He's been working pretty much around the clock on coming up with some of the communications you've been seeing coming out of the IU and the IFTI have been coming through Bernie and Bernie's work. Bernie has experience working in the labor movement with other international unions, with AFL-CIO, CPWR, etc. And we're really excited to have him on staff, in particular at this, especially with this going on, but also moving on into the future. So we've asked Bernie to just provide an overview of what's going on here, in particular as it will impact our members, you guys, and as well as our members. So with that, I'm going to turn it over to Bernie. He'll probably spend maybe a half hour going through the presentation, and then obviously if you have a question, you can chat that, or you can we'll unmute the phones if you have a question. You can raise your hand in the Zoom meeting. So with that, I'll turn it over to Bernie.
Thanks, Tom. Can everybody hear me okay?
Yes, we can hear you. Yep.
All right. All right, well, good afternoon, everybody. Again, as Tom said, I'm an industrial hygienist. I've worked with a lot of large international labor groups over the last 25 years of my practice of industrial hygiene, including construction-based groups like the operating engineers, laborers, and emergency response groups like the International Association of Firefighters, and even industrial manufacturing union groups like the USW. So with that said, my experience in sort of disaster response, I've responded to most national disasters since 9/11, and in some part, whether it be develop training materials, train workers, look at site safety plans, or create site safety plans for efforts. And specifically with infectious disease, I responded under the USW and NIH to the Ebola response, where I developed some training materials, gave some train the trainers to different groups, and also did some awareness training for nurses and custodians who were involved with some of the Ebola hospitals. And before that, I actually did a training tool for the National Institute of Environmental Health Sciences, which focused on pandemic avian influenza. And unfortunately, it seems like after all these things that we've been through, we're still sort of at ground zero with how this response has been going. So with that said, as we go through these slides, it's just sort of a capture of some of the most pertinent information out there. And I'm going to talk specifically towards best practices. And sometimes I'll contrast what you might hear from, federal CDC guidance and what is out there as far as the science, and maybe what other labor groups are looking at doing, et cetera, because you might be able to have picked up on that there hasn't been a clear, concise, consistent message from the response from the Fed. So it's caused a bit of turmoil as we've gotten into this pandemic. With that said, I'm going to go through each slide, and then I'll pause at the end of each one for folks to think about some questions to send in. Excuse me. With that said, if you want to advance. Sorry, folks, I've got asthma. All right. Hopefully my voice sounds okay now. All righty. So the first slide, we've got slide number 2, I should say, transmission of COVID-19. So what the science says and what federal guidance says. What's been fairly consistent from the feds has been it's this disease, this virus is transmitted through droplet transmission. And what that means is fairly large particles that somebody might expel from coughing or sneezing or maybe even breathing, which contain the virus. That's either going to get on a person or some type of surface, and then you're going to have contamination of your mucous membranes, your eyes, your nose, the inside of your mouth. And they've also talked about the possibility of inhaling these particles that contain the virus as well. And with that, they're basically talking about, you know, it's sort of a close contact transmission. So you've heard different guidance numbers, anywhere from 3 feet initially, which was some of the mixed messaging that they were putting out, say, in February. And then you look at some guidance that they would have for other entities, such as police officers. They gave a guidance of 6 feet. Well, you look at that and you say, well, you're telling the public stay 3 feet away, but cops and police officers have to be 6 feet. Well, why is there any difference? So that was some of the mixed messaging about how to distance initially when you're out in public. And what the science has said is that this transmission actually might be a little more complicated than just a droplet transmission. There's been a number of studies that suggest that when people cough, sneeze, etc., that the particles can carry infective agents a farther distance than 3 or 6 feet. In fact, there's a couple studies that show that when you cough, even just talk, that your vapor from your mouth can fill up a room within, or I should say, be able to reach all people in a room in a few minutes. So this would lead one to believe that it could also be transmitted through airborne transmission, which is where smaller particles carrying the virus are going to be able to enter deep into your lung, just like asbestos fibers, and cause a transmission of the disease that way. Some other things to think about is we know that when somebody coughs or sneezes, those droplets that come out of your mouth are going to lose about half of their size in a second from evaporation. So as those particles shrink, they're going to be able to stay suspended on the air longer and travel farther from where they were released. So you can imagine you could be more than 6 feet away and still have some of these particles reach your body, with the potential of having contact with your mucous membranes or breathing it in. The other potential for getting this transmitted is surfaces get contacted. And we'll talk a little bit more about that later, but if a surface gets contaminated with some mucus from somebody's expelling it with a virus in it, and you touch those surfaces, whether it's a door handle or, you know, an ATM keypad, something like that, and then you touch your eyes, nose, mouth, etc., you could potentially transfer it to you that way. So those are the transmission modes that we're looking at. So the CDC has been a little bit more less stringent, I think, in its guidance compared to what some of the research and studies and what I've heard some other folks who have studied aerosol transmission of infectious diseases discuss with some other language. So with that said, who's at greatest risk? You would imagine that it's going to be anybody who is around sick patients for long periods of time. This would be your healthcare workers, et cetera. Also EMTs, you know, law enforcement, firefighters, any emergency responders that might be coming in contact with and spending, you know, any amount of time with folks. Although the ones who are at the very top of that risk pool are going to be your high contact medical folks like your doctors, nurses, physician's assistants, et cetera. You could even throw, you know, custodial workers and things like that in there who are going to be going around all these care centers and trying to, you know, maintain a clean environment for the folks practicing medicine there and caring for the ill. So with that said, as the risk goes down, if you are doing work that puts you farther away from any of those categories of folks being sick, your risk is going to go down. In fact, OSHA most recently, I think their guidance is categorizing construction work as a low risk pool. However, you got to understand that as workers are going to go through their workday or different work sites, and again, this is going to be different for everywhere around the country. That's why it's really important for, I think, every IUPAT local to have a good understanding of this, because you're going to be able to affect that work culture. where your members are. You know, you might have to travel into work and commute. You might be in a work group where the supervisor is not keeping people separate from doing work and things like that. So even though you might be in a low risk pool, there might be times in your day where your risk goes up or it goes down. So it's something to be aware of. With that said, I'd like to move on or pause here and then move on to the next slide. Okay, should I just keep going?
Yes, go ahead, Bernie.
Okay.
I don't see any questions
right
now.
Yes, please.
Okay. All right, so the next slide, we've got social distance and related worksite issues. So as you get on a worksite, there's going to be a lot of different variables that are going to increase or reduce your risk of contracting COVID-19. So some jobs might require, you know, close proximity to other workers. You might need somebody to help you lift something, you know, hanging drywall, for instance, you know, assisting with ladders, carrying things, stuff like that. You might need to have more than one person. That's going to increase your risk. Commuting to work. Maybe you take, you know, public rail or public transportation, a bus or something like that, or a ride share, commute to work with a group of people. That is going to increase your risk. You know, any areas of a job site where you might have, say, choke points or places where people would congregate, you know, where you check in or check out of a job site, meetings, break rooms, lunches, etc. You know, I gave the example earlier today of, you know, porta potties on a job site. If you've got them out there and, you know, one might have 50, 70 people a day go through it, you know, there's 50 or 70 people that could be contaminating something, you know, if they're sick. And I just want to remind folks that you can be sick with COVID-19 and transmitting the disease without knowing you're sick yet. That's one of the reasons why we are so unsure of exactly where we are in the state of infection in this country, because we haven't done enough testing. So we could have a number of people walking around with it or that have had it and are already recovered and never know that they had it. So again, there's places at work where you're going to have higher risk possibilities. And the only way to really manage this is to have a good, strong, centralized COVID-19 work plan that is, I preferably would like to see something developed jointly with labor, but regardless, it's the employer's responsibility and they have to have it on site and they've got to treat it for all workers on site to make sure that they're protected. Another issue with social distancing is different unions or different work groups may have a different level of risk reduction methods for their members. I mean, imagine yourself in a position if you were on a site, you didn't, you know, get any PPE of any kind, and you see a bunch of other workers with PPE on, you know, and then you're told by a supervisor, oh, don't worry about them, they're with a different group. That's not appropriate in this kind of circumstance. So we need to make sure that we have the same message. And you've probably seen now a number of news broadcasts where you've got, you know, a video taken from construction workers' phones where they're showing, you know, too many workers together. They're showing some in PPE, some don't have PPE. So these are really mixed messaging that's going on. It's not making for a very confident ability to handle this pandemic. All right, we can go on to the next slide if there's no questions.
So far, so good.
All set?
Yep.
All right, so one of the factors in how we're going to be able to reduce our risk is understanding how this lives outside the body. And as I speak, I mean, I got off the phone with the folks this morning, and already more information comes out about this, but some of the stuff that we've seen so far is that it survives outside the body, and the survival length is a little different on different types of material. And when I'm talking about survivability, I mean with the ability for that virus to still infect somebody. So what we found is that on cardboard, it could live up to about 24 hours. And I'm going to use the phrase about because it could live 20 hours, it could live 26. People just don't know that tightly yet. these kind of details. Copper, it survives quite a bit less. It's around 4 hours, and that could be because of the toxic properties of something trying to live on copper. And then plastic and stainless steel was found to have a transmissibility upwards of about 72 hours, which is a pretty long time. So, you know, this is going to put things in perspective. So, I mean, if you're working and, you know, you're grabbing tools, maybe you share tools normally. You know, tools are made out of hard stuff. They might have plastic handles. They might have, you know, steel handles, etc. These are all places where this stuff might be able to survive. Not to mention, so one of these work plans is, you know, guidance is you want to make sure that you're not sharing tools if that's something you normally do, or if you do, you have to take the time to try to wipe them down and clean them before they're passed on or you pick them up. You might have seen, you know, some newscasts, and even the CDC had a statement, but it was taken a bit out of context. And the CDC, I guess they revamped their language a little bit on it. There was a cruise ship that they measured, you know, some coronavirus that was there present 17 days after everybody left. And what they actually found was, you know, the genetic material left behind by the virus. It wasn't actually living virus, which is able to infect somebody. I think it was RNA that they found. So again, you're going to see a lot of, you know, stuff come out about this, but we want to make sure that we try to verify the information. And then, at least from a labor standpoint, what I would like to see done is take the information there and then apply it to develop best practices. I'm not so much interested in the minimum protection standards right now, especially because this is such a moving target. And we've got a ton of, you know, really brilliant, hardworking scientists, epidemiologists, doctors, researchers all over the world trying to fill in pieces of this puzzle. But because it's moving so fast, people might come out with a study, they might have a bit to share that it might not be peer reviewed yet, it might be relevant, it might not, it might be relevant for some people, it might not. So I think if we're taking the stand, especially in labor, and following the standpoint of best practices, I think it's going to be better off in the end, especially since this is such a fast moving target. So with survivability, there was a recent update that came out just a couple days ago about the virus surviving on the bottom of people's shoes for up to 5 days. And it could be found on other parts of shoes as well, depending upon what kind of material it was. So you'd imagine, just like working on a hazardous waste site now, right? This could potentially bring home contamination to your family members, right? And you don't necessarily have to pick it up at the work site. You could be traveling back on a bus, and, you know, something gets on your shoes that you bring it back, you take it off at the house, you know, you hug your kids or something like that, those kinds of things, and, you know, possibility for transfer. So we have to think about how can we eliminate the risk now of bringing stuff home on our work clothes. So we want to try to leave contamination at work as we would with asbestos or any other hazardous material. Okay, next slide. All right, now this has been sort of million-dollar questions here on PPE and face masks. And we literally just ended one of our calls with the group this morning, and I just saw that Dr. Fauci and the CDC are now talking about, you know, whether or not we should consider having medical face masks for the population. So I'm going to start with this one first. Again, this is some of the mixed messaging which caused a lot of confusion, and it is still causing confusion. Back in, I guess, you know, early February or so, when this first started to be talked about publicly, the feds are saying, don't wear a face mask if you're not sick. It's not going to protect you. And by the way, we need to save them all for our medical personnel to protect them. Now, this sends a message, it doesn't protect you, but it protects them. So which is it? It can't be both. So this is one of the mixed messages, and they're talking about, you know, whether or not you should be wearing N95s or other types of respiratory protection if you're a general public everyday person, or if you should be wearing this depending upon what your risk group was as a worker. So a few of the experts in China that deal with infectious disease there. I remember back in January, I saw a couple pieces about them talking about one of the reasons why we were controlling this quickly based on the population we had is because everybody was wearing their face mask, and they were talking about a medical face mask. And I know that other infectious disease experts talked about this as well. And it's been argued at here, in the United States back and forth. And I'm even seeing discussions about, other industrial hygienists talking about the validity of this. And now it's to the point where, the CDC is looking at it. One of their concerns is that, and I think this is one of the reasons why they spoke this way, again, just my opinion, is that if everybody went out and bought these medical face masks, there would not be any available for our medical practitioners who are on the front lines of caring for all of us. And we've already seen that there's the significant need for PPE because we don't have it. So the use of a medical face mask is still debated, which leads us to the N95s. And then there's also an N97 and N100s. These, again, things are a critical shortage. I'm reading updates many times a day from medical practitioners on the front lines talking about they don't have the basic equipment to use. These things are going to protect you against the particles that are small enough to get down to the deep lung that can carry the virus. And one of the issues that they're looking at is whether or not they can reuse this stuff. In fact, I just got something when I was eating lunch from 3M that said that they went through all the available sanitization methods for their filtering face piece respirators, so the N95s to the N100s, and no method met their 4 criteria for being able to reuse the respirator, so they didn't recommend it. And this is from 3M, one of the manufacturers. But then again, I saw another study from a doctor who was using hydrogen peroxide steam to do it, and they thought that it did a good job. So again, the science on this and the discussion is happening as we're going about it. Should you be trying to sanitize and reuse something that's meant to throw out? No. That's the industrial hygiene best practices line is no, you're not. However, what am I going to tell, somebody on the front lines, a nurse or a doctor who that's all they've got because they're not getting another one from their employer? It's a really tough situation. So I'll set that aside, but just understand it appears that there is no good way to sanitize these things for reuse as it right now. What we need is more, and we don't have more of them. So that's where we're stuck. The next thing that is good, it would be elastomeric HAP or full face with a HEPA cartridge. Like a lot of your members are probably used to wearing who do painting and work around hazardous materials. Back about 8 years or so ago when I was doing some work for the SEIU on developing respiratory protection fact sheets and guidance and things like that, it was my first sort of preview into this world about nurses and fighting to get elastomeric respirators. Hospitals just did not want them to have them. Come to find out why, it's too expensive, takes too much time. They have to be on a medical, surveillance program, things like that. So it was always a fight back then, and so it's no wonder why we are, sort of stuck in this situation now. Which leads us into eye protection. It's one of the membranes that this can transfer to. So if you're going to be in a work situation or a personal situation, like if you're caring for someone who's sick, at your house, and you can get coughed on, sneezed on, et cetera, or you can contaminate your hands where you touch your eyes, then you've got to have something to protect your eye membranes, which brings us into clothing. If you're in a type of a situation where you might contaminate your clothing or your hands, your face, you might need to wear some kind of protective garments. These, again, are something that's in incredible short supply. With that said, all of this stuff, though, this PPE that we could use to reduce our risk of transmission, the people have to understand how to use it, how to properly put it on, how to properly take it off, what the limitations are. How to store it if it is reusable. For instance, you can have gloves on to protect contamination to your hands, but if you touch something that's contaminated and then with that gloved hand, all of a sudden rub your eyes, you didn't do any good. Right? So we have to make sure that folks are trained on how to use this. And unfortunately, I mean, you've probably have your own feelings about this, especially being involved with, you know, health and safety and worker empowerment training, things like that. Many, many employers probably haven't done the basic of this stuff, what was needed to be done before we had an outbreak like this. So I've heard a number of different, you know, folks in the IAPAT tell me how it's a fight sometimes on a daily basis to get, you know, work environments to do the right thing for their workers. Now we're stuck in this situation where you might not have an employer who had these programs in place to begin with, and now they're really trying to step and fetch to get something in place to work. I gave the example earlier this morning where the transportation unions and authorities at some different cities were talking about, they had plans that were created because of the swine flu outbreak. And the plans basically had them get PPE, so they had some stockpiles, but only enough because all of the plans were depending on a strong central response from the federal government, which unfortunately has not come yet. So we're having states, large cities, municipalities, et cetera, trying to work their way on their own on this, at least in the time being. So again, if you didn't have a plan in place, if you don't have training, if you don't have the stuff to begin with, the PPE for this, you know, is going to offer, you know, some protection. It could offer limited to no protection depending upon what it is and how you're using it. The best thing is risk reduction, is staying away from folks. All right, that's it for slide 5. We could move on if there's no questions.
I do not see any questions there, Bernie.
Okay. Okay, so how long will this last and what happens next? So you've probably all seen discussions in the news about the peak. When's the peak coming? There's been dozens of different epidemiologic models, and epidemiology is the study of disease in populations. I'm not an epidemiologist. I had to take a couple of biostatistics courses in graduate school, and thankfully I don't do epidemiology because it is very hard to track all of this stuff. And I think the folks are doing a great job at a very fast moving target. But a lot of these models and people who are using and developing the models will tell you they're not for certain and they're going to move, especially because we don't exactly know how many cases we have right now. Right now, at this point in time, we don't know how many cases we have right now in the United States because we haven't done the testing. With that said, I've seen modeling anywhere from having a peak of 3 weeks out to 6 weeks out. It really depends what kind of location you are. If you're in a big city, if you're more in a rural area, what part of the country you're in right now. So as far as when this is going to start to end, we don't know. And again, it's going to be different for all different places of the country. I have seen August and September is when things will, you know, likely be completely back to normal. But again, you don't know. The other thing to consider and, you know, to discuss with your members is everybody's talking about the peak, and I can't wait to find out when the peak around me is going to happen, although I found out that it might be April 21st here in New Hampshire. So that's great. But we have to remember that we marched up a mountain to get to the peak. We still have to come down the other side. And it doesn't necessarily mean it's going to look exactly the same as we went up. It could be a sharper slide down where, you know, fatalities and cases drop off quickly. It could slope down at a different angle than how we got up. Who knows? Who knows? So that's something to consider. We have an idea. It's a moving target, and it's going to be different for different parts of the country. Which brings us to return to work. For those who might have folks working now, it's imperative that you have an implemented COVID site work plan and that you follow it. And it's also imperative that you are following all the necessary risk reduction precautions in your home life. And I say we need to look at this as reducing your risk. So not any one thing is going to do it magically. We need to be able to put together different risk reduction approaches like the social distancing, using hand washing, hand sanitizers, using PPE when you need to. Make sure that you're monitoring for symptoms. You're calling your healthcare provider if you think you're ill, these kinds of things. So when we do return to work, that's going to have to be deliberated upon. What we don't want is to have the floodgates open, everybody go back to normal life, and then we see a second spike. So we have a double peak in an outbreak. And that's like what they had back in the 1918, 1919 flu. There were two peaks to that. So we don't, once this first peak is done, we don't want to see another peak. That's the goal. And how that happens, it could be staggering people back to work. It could be, releasing different trades and jobs back to work. I don't know yet. But it can't all be done at the same time and as normal. I do know that there's going to have to be some kind of guidance in how we do that. All right. Any comments or questions? All right, next one. Okay, so this is sort of winding down this discussion here, sort of like one of the statements I just said, transmission risk reduction techniques and issues for applying them to a work site. There are a whole host of things that we can do to reduce the transmission risk. But again, it's got to be done by a central plan that governs a work site. It's going to do you no good if you got one group of workers always washing their hands and using sanitizer and the other group doesn't, and you're all touching the same stuff. It's going to do you no good if you're congregating in groups and some people aren't. So there's got to be a central plan, but anything you can do to increase distance, and again, the Fed guidance right now is 6 feet. We've got plenty of research that shows, depending upon the kind of environment you're in, whether it's in a closed room, a bus, things like that, that 6 feet might not be enough. So this is something to take into consideration when developing these plans. What kind of PPE do you have? Is it your own stuff? Is it disposable? Is it reusable? Is it designed to be reusable? Are you going to wash high-touch surfaces constantly? Is somebody in charge of that at the site? Right, so is each worker left up to this on their own, or is somebody going to be in charge of coming around and making sure all the porta potties are sanitized however many times a day, making sure that, high touch pads, things like that, clock in, clock outs, are those things cleaned consistently? What do you do for drinking on site? Is there going to be a requirement for everybody to bring in their own water bottles, things like that? Whatever the techniques are, you got to make sure, again, that they're written down, they're on a plan, and that they're going to be consistent. And then you have to make sure that what is contracted potentially at the site doesn't go home. If you've contaminated your shoes, your clothing, you don't want to bring that with you. If you were fine when you left the site, but you got on a train and it had, 50 people in your car, you don't want to put yourself in a position like that, because that's taking something home. So you have to think about how to reduce your risk while at the job site, and also getting to there and getting home from it. Okay, next thing. Okay, so this is the short course that the IUPAT folks got on the learning management system. I took it. I think it's a pretty decent introduction to what COVID-19 is, with some general precautions. I did notice that there were a couple things that were either already outdated or a couple contradictions in the course. It was nothing major. I think what would make this more usable is if you would just give an update sheet to this maybe once a week, because things are changing so quickly. In fact, when I'm done with this call, I no doubt I'm going to check my inbox, and when I already find stuff I just said might have changed a little bit. So I think the course is fine. I would just consider adding some kind of an updated guidance sheet or something to it to have for attendees to grab.
So Bernie, if I could just add to that, this is Alice. We are looking into some other courses as well that might be web-based, so that the information is provided on a timely basis. So this is a great little introduction, the COR 195, and we're looking at a couple of other e-learning type courses that we will add probably to the same course code for everyone to access. And when that happens, we'll send an email alert so that everyone knows that that's available to you.
Okay,
Bernie, we
you.
do have a question.
Yeah.
So someone is asking, Joe is asking if you are recommending that members wear respirators on the job site.
Oh, this is a tough one. It depends what their job site looks like, how close are they going to be to people, where are they located in the country? Is it like a big city? Is there a known outbreak cluster? If it was me, like what I do, if I'm going to go out somewhere, first off, I haven't went out to any crowds. Like I go out and I do my shopping and I get what I need to get on off hours. So I make sure that there's not a lot of people there. If I were to have to go out and stand next to a group of people, I would put on a respirator. I've got asthma. I had 2 sinus surgeries. Even though I'm only 45, I'm in pretty good shape. I can run Spartan races up Killington Mountain, but if I don't have my inhaler with me, I ain't making it off the mountain. So I'm in a risk area where I would want to put it on if I'm going to be around crowds and I can't social distance. I would say that you need to have a discussion with your local union, with the health and safety representation there, and come up with a plan. And I don't know, maybe something like this too could come directly out of the international, where everybody agrees on what should be done and then you do it. I think that's the best way I can answer it for now. It depends what your risk factors are on that job. And let's say, here's an example. Let's say if you're going and doing a job that's at a hospital because they need something done. Ideally you put work off at a place like that right now. But what if you're going and building some soft wall containments or something? Or maybe there's something that's in critical need of repair and you're going to a site like that. You'd absolutely want to, bring a respirator with you because you're going to be putting into a very high risk environment for transmission there. If you are by yourself and you're going out to do some work where you're going to be the only person and you just get in your personal vehicle and drive there, you wouldn't need it. Unless you need it for, the hazardous materials that you're going to be bringing with you. Does that answer your question?
Okay, I think Joe, I'm going to unmute you because I think he wants to speak. Or Donna, can you unmute him? Joe?
Hello?
Okay,
Hi
Joe?
there.
Hello?
He's on. Oh, okay. You're good, Joe.
Okay. No, I didn't have, I just wanted to know if that was like, he answered the question well, because I wanted to know in a hospital setting, because here in DC6, we work in a lot of the hospitals and we have members working there now. So they should wear a respirator if they're working in the hospital. Even if, but to clarify it, do you need to wear a respirator in the hospital if you're working like on a site that, where it's not in the general public, you're just on a construction site where maybe they're remodeling a wing or putting up a new building?
So it would depend how well you're going to isolate that work population, from the rest of them. And so here's something to think about. This is a really good question that you brought up, because I've read 3 articles in different parts of the country where doctors or nurses have worn their respirators in the hallway and in public areas like a waiting room. And they were reprimanded by hospital administrative staff and said, you can't do that. And they continued to do it, and they were all sent home. In fact, there was a doctor at El Paso Hospital in Texas that was 60 years old. He has hypertension and he's got asthma. I'm wearing my respirator everywhere because it protects me and it protects them, everybody around me. And they sent him home put him on administrative leave with no pay. And this has happened to a couple nurses I read about as well. And it's probably happened to more than just 3. That's just time I've had to read into it. So here's something to think about. And again, I'm just trying to brainstorm this because this is new for everybody. what happens if you're doing best practices and you're protecting your work group, right? And you go in there with respirators, and here comes some hospital administrator that says, no, 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 no. You can't wear these around here. You're gonna freak people out. There's no need to wear them. You know, the patient care is happening, you know, 5 hallways down or something. What's the response? You know, this is something to think about it, because if it happened to doctors and nurses who are on the front lines doing this, what's going to be the response if you're in somebody's building protecting yourself appropriately? And I don't know if this is something that you can get in, you know, contract language or something, if that's where you need to go with it, but I just want to put that out there as a potential of something you might get pushback. Does that help?
Yes, and then I have another question.
Sure.
What cartridge would you recommend? Because most of the time, most of the painters just have the carbon cartridges. You know, I don't even know if you can get those pink ones at Sherwin-Williams anymore that were for. So
yeah.
what would you say to you?
So the carbon ones are just for organic.
Vapors,
organic vapors. Yeah, so you need to have the pink ones, the HEPA cartridges, or the combos, like the magenta and yellow or magenta and white, something like that.
So
what you want to have the HEPA ones.
So if you had the carbon and then just put the pre-filter over it, that's not going to do any good either.
Is it sort of like this? Yeah, no, you got to have the HEPA material. You got to actually have the magenta colored HEPA. Yeah.
Okay. All righty. Thank you.
You're welcome.
Okay, we have another question. Actually, there's a couple of questions in this from Rich. On construction sites, I'm just going to read what he's written on his chat. On construction sites, will it help if you have the workers work different shifts where less people are on the job site at the same time? And should we sanitize and clean between each shift? A job near us in Massachusetts is checking people's temps before they go on the job. If they have a temp, they're sent home. Is that good practice?
Okay, so the first part of the question, or the first 2 parts of the question, yes and yes. If you can stagger work so that you've got less people on the job, where there's greater opportunity for them to be apart from each other and not bump into each other, that's a good practice. And there's a number of charts out there, they're infographic models that'll show you what happens if, you know, you've got 10 people together, how many transfers that might look like. And then if you've got 5 people together, you see the reduction in transmission than if you've got just 2 people. So that's a good practice if you can do that. So adjust work so that work's being done differently and rearrange work, right? So that's a good practice. So yeah, so checking temperatures. So there was just a question asked in the outbreak group, the AFL-CIO outbreak group. Somebody thought that it might have, it might violate the Americans with Disabilities Act and another federally protected law, but I don't know what the CDC says offhand. Here's what I do know is that there's questionnaires that are out there, right? Although checking somebody's temperature, thinking about it, is the same as asking a questionnaire. You know, if people have symptoms, they're asked to stay home, right? If you get to work, in fact, I don't know 100%, but this might actually be in the CDC guidance for protecting businesses against COVID-19, where they say, you know, you should have a check-in about symptoms for employees and make sure that they're allowed to stay home, et cetera. Checking a temperature isn't a bad thing, as long as it, you know, doesn't violate anybody's rights and things like that. But under this circumstance, we got to make sure that people, you know, are not coming into work sick. So I think it personally would be a good idea. I mean, you know, when I thought that I was feeling ill, I was checking my temperature a couple weeks ago. But again, I don't know how a collected group of people would feel, and I don't know if that violates any particular worker rights out there. I have seen that actually. I've been paying attention to the Boston news quite a bit, and I've seen a number of news feeds where construction workers are having their temperature checked before they got on the job. And I'm sorry I can't more completely answer the question, but there's a couple of pieces there that I'm not 100% certain on, and I don't want to give you information that I'm not 100% certain on. Good idea, yes. Is it applicable for the work site? I'm not sure.
Okay, so there's a little bit of chatting going on. There's one question, is the FTI going to send recommended protocol to the contractors? And then there's a little bit of chat about the N95, if that's minimum, if a P95 pre-filter over the organic cartridge effective or not.
So I'll leave what the IUPAT is going to do for contractors up to Tom and Anton answering that one. As far as if for the respirator question though, as long as it's a HEPA filter, or if it's even you know, an N95 or N97 filter, and when I mean HEPA, I mean N100. So an N100 is 99.97% efficient at filtering out particles down to 0.3 microns. Tiny, tiny, tiny. Never going to see that. That's a HEPA filter. The N95s are 90% efficient at doing that, and the N97s are 97% efficient at doing that. As long as they've got one of those NIOSH designations, they're good to go. Doesn't matter if it screws in or attaches before the organic vapor cartridge or after.
Okay, thank you. Does anybody have any more questions about that?
Yeah, Al, there's a question from Daniel, so I'm muting him.
Okay.
He raised his hand.
I got on this late, and can I redo this or not?
We're recording it, so we'll send out a follow-up with the recording.
Yeah, I got my computer wouldn't. We lost our power last night, and our computer wouldn't work.
Okay, no problem. We'll send out a recording of the whole webinar.
Thank you.
This is Tom here. So Bernie, myself, in working with Anton, we're putting together a guidance work plan for the members, and we will serve that over to the IUPAT, and they'll take that and use that how they see fit as far as distributing that to employers. So, but that's something Bernie again has been working on, and we hope to have that shored up tomorrow night or by Thursday to serve that over to Nextdoor.
Okay, and we have a couple more questions that have come in through the chat. Someone says that they read on the 3M website that the K95 mask is effective against bacteria. Can they use those, that type of mask?
So it said it's effective against bacteria, but this is a virus. Right. So I'm not sure. I'd have to go to the N95, to the 3M website and look at what they're speaking to.
Okay, and then the next question is, it says washing your PPE with soap and water. Is that the proper care?
So you want to follow what your manufacturer's recommendations are for sanitizing it, because you don't want to use any kind of product that might degrade the system itself, like the elastomeric, face seal, things like that. Soap and water, I think, is probably the recommendation for a number of different models and brands of elastomeric respirators. But you also might be able to use, some gentle alcohol wipes, things like that. So you want to make sure that you're following the manufacturer's recommendation. And I don't doubt this. You can probably find the guidance for sanitizing and washing your usable respirators right on all of the company's websites, because COVID-19 is first and foremost on, 3M's and North and all these companies' minds right now. So what I would do is, and this goes to answering to the question too about, what respirator will protect against what. If you have any question, you want to get it in writing from the manufacturer of that respirator, whether it's 3M, North, or whatever brand you're using. You want to make sure that that filtering material is going to do it if it's something you're not familiar with. If it's a HEPA filter, you're good to go, okay? If it's an N95, it's going to be, 95% efficient. If it's a 97% efficient. But just make sure if you have any question, you either get it answered by, an industrial hygienist, or that you find it in writing. And that industrial hygienist should be able to back it up too. That you get it in writing from the manufacturer. It's very important. Let's see, am I still on?
Yes, you are.
I just want to sort of round up that last bullet, adding additional courses related to COVID-19. Tom mentioned the ICRA course, where it's an infectious, risk reduction course, and it includes building of, soft wall containments, like with polyethylene barriers and either 2x4 or PVC piping or zip walls. There's a bunch of different methods. So those are kind of useful courses right now that folks could consider doing. And I think there's a way where you can do it online, and also solo, building of these things, demonstrating it, that kind of stuff. But another thought that Ken and I had, and I think this would be good for all the local training centers and unions as a way to serve their members right now and empower them with a unified amount of information on this. If folks have their own elastomeric respirators, or maybe they've taken a bunch of the training already, but they don't have their own respirator, you could actually have some in-person training as long as you set up your training centers in a specific way. And what Ken and I discussed was, maybe you've got someone that has their elastomeric respirator. It hasn't been fit tested this year yet. They bring it in. And I don't know exactly how this would work, but my thought is you would stagger students coming into your training center so that there's no more than 1 or 2 of them together. And you have 4 or 5 or 6 different training stations that are separated by some distance, 10, 12, 15 feet, or maybe held in different rooms. And then you've got a trainer at each station that will facilitate that station, and they're protected. And the first one would be, how do you clean your respirator? So you would take your own personal respirator, or one would be issued to you if you don't have one, and you go through the cleaning process for it, and then you set it aside to dry. And you're also discussing their maintenance and storage of that. From there, you go and you sit down. You can take a medical clearance evaluation. Make sure you're good to put one on. And I was told that you can do that, right away on the spot. Then from there, you can go to a facilitated like PowerPoint presentation, where you get the down and dirty and a review and a refresher, if it's new to you, new information about COVID-19 response and wearing PPE. So limitations of the types of PPE that's out there, the issues about respirators, what are the employer's responsibilities, what are your rights as a worker, et cetera. And then from there, you could be given your respirator back, and you actually have a quantitative fit test right there. And so that your respirator is now fitted again to you. And then the last station would be a facilitated demonstration of donning and doffing PPE properly, and you would use your own set of PPE, and then you're out the door. So if this is done properly, you would have workers staggered, so they're either individual, they're not in groups of more than a couple. All the trainers are protected. Everything, all the stations are social distanced. You're able to give a worker a method, a hands-on method of cleaning their own respirator according to the manufacturer and how it should be done. You get them medically evaluated if they haven't done so, or maybe you redo it. You give them the pertinent training information specifically for COVID-19, and then they get the opportunity to get a quantitative fit test, and then to try it on and take it off in the appropriate methods, and they're out the door. I think if you came out with a training plan like that, that was central, but then given out to all, the training centers, we'd be having everybody do the same methodology. You'd be giving very pertinent, very useful information to all workers, and you're giving them benefit of either a respirator or a clean one if they don't have one, and fit tested and medically cleared. And then they'd be groups of workers who are empowered by the same information to collectively be able to get what's right through the local unions on a job site. Because I've been told from folks, that they might have gotten respiratory protection at some point, but it falls through the cracks on sites for the employer, whether they're not having them keep up with their, maintenance and storage and cleaning, things like that. They're not getting them fit tested when they should. So it's just a thought of ways that you can take some training right now, open up your training centers, give a service to your members, very functional and important service, and sort of unify the union, under this message of how to use PPE safely and all this other stuff. So just a thought. And I think that's it. Hopefully nobody has fallen asleep, and who knows, maybe I have a bunch of people now that want to be industrial hygienists. I can only hope. Any comments or questions?
Okay, there was one more. I'm not sure if it's a comment or question. I'm just going to read it right out. We are not currently using quantitative testing, only qualitative. With the QualiFit machine drawing air with their masks, we would be putting everyone at risk. Let me read that again. Or let's what? Can we, Donna? Can you unmute Justin Oshel? Justin, you want to ask your question?
Yeah, so we have done a couple respirator fits at DC6, kind of an emergency situation with some of our bridge painters going out. And we haven't been using our QuantiFit machine because we're worried that we're putting them at risk by having that machine draw air from inside their mask into the pumps in the machine. And we don't know enough about how that machine works. I don't think it filters anything, so we don't know if people that hook up to the machine next are breathing in some of the same air that the person before was.
That's a very good question. I believe that the air is filtered because they have to protect the integrity of the machine itself. But what's the brand of machine that you use? Is it like a Port-A-Count?
It's a QuantiFit.
QuantiFit.
So we've just been doing the
Okay.
qualitative with the smoke.
Yep. Okay. So that's a very good question. I would, call QuantiFit and have them answer that question for you about what the ability is of that machine to make sure that the air to the next tester or testee, I should say, is not contaminated. And is there a way that they can decontaminate or clean their piece of equipment if there is no filtering mechanism on it? The other thing that you might be able to do is put a HEPA filter in line when you're doing you might be able to do that. So I think if there's not a system on there to do it, to filter the air, they should be able to come up with something to do it.
Okay.
Yeah, that's a good, because, you could have a member who's got the disease, but they don't know it.
Yeah, because when they're in between the actual individual tests, when somebody's hooked up and they're breathing, they're inhaling and exhaling air through the hoses.
That's
So,
right. Yep.
I understand the machine probably filters itself, but those hoses, you're breathing air in and out of those hoses that the person before did.
So what you'd want to do then is it just Tygon, like Tygon tubing, or are they like corrugated?
Yeah, just the clear plastic.
Okay.
tubing.
Yeah. So you just throw them out. Have them disposable right now. That's one way you can go about doing it. Just cut new tubes each time. Okay, I just looked up QuantiFit's site here. I just want to see if they have anything.
Yeah, their hoses are permanent connections, so it's not like something that you just cut hoses in.
All right, I don't see anything specifically on their website that's just jumping out at me. But even if they're permanent, you should be able to get an adoption system for them, because they are just polyethylene tubes.
Yeah.
So I'm sorry, I can't answer that definitively right now. So I would reach out to them and call them. And if you don't get a satisfactory answer or understanding, give me a buzz back and I'll try calling them and talking with them myself.
I just want to put that. I wanted to put that out for everybody because there may be people still using that machine, assuming that it's safe.
Yeah.
And just wanted to warn everybody.
Yeah, so if any other questions come up after the call, you can send your questions to the FTI International mailbox, and we'll pass them on to Bernie. And then we'll figure out a way that we can put them all together and share those back with you. I do think we have one more question.
Okay.
Everybody's still here? Okay. If you're working and find out that a coworker's family member tested positive for COVID-19, do all that came into contact with him or her self-quarantine? What's the protocol?
Yeah, so the CDC has changed this recently, and I don't recall seeing the last updates. So if you have a family member that's tested positive, you yourself would then be in a presumptive case. At least that's what they were saying. So then you would self-quarantine for 14 days. But I do not know if they have updated that or changed it. I think there was a flow chart. There was another union group that was actually asking something similar, if there was like a flow chart or something like that. And I think CDC actually has something like that. So I can't answer that one now off the top of my head.
Okay. I don't see any other questions. Let me just take a quick glance to make sure there are no raised hands. Okay. So, Tom, did you have any final words before we close out the webinar?
Sure. Thanks, Alice. Thanks, Alice, and thanks, Bernie, for this information. Moving forward, look for some additional guidance. Know that you have also, besides emailing the FTI International, you have your ATRs that are out there who can assist as well, or take those questions and we can get a response back to you. Also would encourage you again to continue to use the learning management system as ways to deliver training at this time as well for your students, not just on the virus, but also some of the curriculum that exists in there moving forward from that perspective. So again, we appreciate your time and reach out to us if you have any questions or concerns.
Okay, well, thank you, Bernie, and thank you all for getting on. And once we receive the recording from Zoom, we will be sending that out and probably putting it on the LMS as well as part of the course materials. So thank you. Everybody stay safe out there. And that concludes our webinar.
Thank you.
Thank you, everyone.
Thank you.
Thank you.